But I think if we could show the hip drops, we could show the obvious things to them and without putting a number on it and say your right side's dropping more here and freeze frame it in certain motions and say it's dropping here. And then when we go to do a single leg hip abduction exercise, whatever, this is why we're doing it, because remember when you hip drop and this is what in function standing, this is what we're looking at. And so we kind of definitely relate it back to what we saw, and this is why we're doing it.
Doug Adams here from Run DNA Podcast, and we've got a great episode with Paul Drumheller, and I'm really excited for this one. This is a deep dive into some foot and some walking gait mechanics, and it's really appropriate timing for two reasons. One, Paul has his new course coming out, When the Foot Hits the Ground, online version, and that's a great course if you really are looking to deep dive into foot and biomechanics and everything going on there. I highly recommend that. We're also taking a little break because we're working on our own walking course, and it's much more about gait analysis and looking at the person as a whole. Our gait capacity screen, which is similar to our runner readiness assessment, but specifically for gait, and how we classify walking gait patterns. So we're going to take a little break for a couple weeks while we're filming all of the content there, but look for early fall. Lots of information coming out about the new walking course that we're putting together and our new walking protocol for our motion analysis system, which I have been testing and I am thrilled with and so excited for it. So I'm going to be geeking out about walking and just how this is really important for sports medicine providers to understand biomechanics of the foot, on biomechanics of gait. And I think that that's really important to understand. So you'll get a lot out of this. In this episode, Paul and I even talked about some tests that he uses that I incorporated in my practice, and we had a lot of great information. So a great listen. Enjoy this for a little bit. We'll be back in a couple weeks, and we'll have some fun running and walking topics as we talk all things gait from Run DNA. Thanks for listening. Enjoy the episode. Hey everybody, Doug Adams here from Run DNA Podcast. Very excited today to have Paul Drumheller on. So Paul, welcome to the show. Thanks for being on here.
Thank you. Yeah, thanks for having me.
Yeah, this will be fun. So Paul and I, every time we see each other at a conference, I feel like we're just, oh, hey, there's Paul, like there's Doug, let's talk, let's kind of chat. We kind of talk nerdy about stuff, about gait, about feed, about all that kind of stuff. Yeah, so excited to have you on and talk a lot about foot stuff today and go into some gait and talk about some of that stuff. And so maybe I'll do a quick intro just so the audience knows, and we'll do some rapid fire questions kind of for people to get to know you. So for those of you not familiar with Paul has 30 years of experience as an orthopedic and sports physical therapist, owns his own practice in Tacoma, Washington. Three-dimensional PT is the name of it?
Yes.
Right? Yes. Perfect. And you've had that for about 20 years now, you said, right?
Yes, I have. Yes, going strong.
Right. That's a big milestone there. That's huge. That's not a lot of people get to say that.
I get a few years left in me, few years.
There you go. Good. But also on the continuing education side, and this is where Paul and I like to really share a lot and talk a lot. He's the owner of a course called When the Feet Hit the Ground, Everything Changes. And I don't think we've ever talked about this, but I took that course as, I think, my second ever continuing education course. When I first came out of PT school, it was something that I knew. I think it's a great title, great course with that. So definitely interested to hear how the course has evolved in the last more than 10 years since I've taken it there.
It's been over 30 years. Yeah,
30 years that course.
Going, so yeah, I took it back in 2003 when I was starting out just opened my practice, and I didn't want to open up and say, we're great PTs, we're generalists, we treat everything and we're best at everything. I didn't want to do that. And I think that generalists eat last, and I wanted to be a specialist. And so I took this class, When the Feet Hit the Ground, Everything Changes. Came home, confused as heck, by myself. At that time, the course did not talk a lot about treatment stuff. It was, here's the foot, look at it and find it. And we found it. Back in those days, everything had a measurement, if you remember that. And you had to measure everything. Completely different nowadays. But I took and came home confused. I didn't have a mentor. I didn't have anyone in my area as foot and ankle to talk and bounce ideas off of. So I contacted the group and said, can I lab assist? So I lab assisted for the group for about 7 years up and down the West Coast.
Wow.
At the time, there were 8 individual instructors, and I would just, I could hear the course every time. Every instructor taught it differently. They had their own little bits and pieces that they like to add in.
Yeah.
Although the manual was the same for all that. And then I would literally stand next to the instructors and listen to the questions that they fielded and think to myself, how would I answer that? And then how would they answer? And so I started formulating my ideas. And back in those days, when Video Gate was kind of just starting, I've got pictures of me with the camera on the box and run and jump on the treadmill to watch myself walk and just to practice that.
Yeah.
And then so I started lab assisting, and then I finally came on to be a speaker. Dave Nolan took over just the year before I did. And then Brian Hoke, one of the main guys, one of my mentors, still a good friend, he left. And so that allowed me to come on. Now, I was not going to fill Brian's shoes, but allowed me to come on. So when I got the class, they said, here's the class. They did not give me any objectives. They gave me the manual. Said, here's the class. No slides, nothing. So I created it, my own. I put in a lot of videos, a lot of exercises, a lot of treatment stuff. And I spoke the first couple of sessions, and the class just ripped me. And they ripped me because I did not follow the manual. That was 20 years old. It had never been updated.
So it's like, well, hold on, this isn't the same as this there. Yeah.
So a little bit of tug and pull. So Dave Dolan and I got together. We taught the last class for that group in Boston. So afterwards, we're sitting at a bar and writing on a napkin like we did back then.
Yeah.
And we basically said, this class sucks. Well, we can't do it anymore. And so I basically threw my name in the hat to say, I want the name. So if the course ever sells, I want the first right of refusal, and I want to buy the name. They can have the manual. They can have everything with it. I want the name. Took almost 2 years to do that, but the two brothers that own the company, they finally agreed, and I was able to buy it and buy it at a definitely reduced price, which was good. And then we took over. We started teaching back in 2016.
Okay.
And the course now, the manual is updated often. We just did it again this February. But also in fairness, there's a lot more research. There's a lot more trial and error. There's a lot more experience. So, and we can do that now and do it safely and confidently. We are able to do that. So we took it over, we did it, and it's been good. We've probably had 8 classes a year, and then of course COVID hit, and that threw everyone, including threw everyone back, and then everyone wanted to go online. So we thought about it, and just procrastinated. To be honest, we all knew we wanted to do it, but everyone's busy. And so finally, earlier this year, we were able to get together. I flew Dave out, and we got together in my clinic, and we recorded everything. All up-to-date research, and so now we're putting together. It should be out very soon.
Great.
And so give people options to travel, because it's expensive to travel. And I get it, but still, it's good content, new stuff all the time. We'll have the labs will be recorded, so you can practice. We got great demonstrations, great video of it, and I'm excited about it. I'm happy about it. So,
nice. Congrats. And this is something we've talked about a lot. We had a similar with Run DNA, where we used to teach all the courses in person, and then everything went online. And we get a lot of great feedback. I mean, I had somebody tell me the other day they've taken the course 2 or 3 times, and that makes a big difference of them comprehending the information and really feeling like, now I learned it. I used it with a couple of patients. I went back to the course. I now really soaked a lot more of it in. So it's all about people actually applying the information, as opposed to just like sitting in a course on a weekend and just being able to regurgitate it for a test.
Yeah, it's tough. There's a lot of information in this class. And I can't tell you how many times I went back and looked at the manual and called somebody or whatever and said, hey, is this right? Or is this what I'm seeing? And went back and forth. But people are not going to, I don't expect them to geek out like we do on it, but but we do. And that's what I like. I like the intricacies. I like learning what should happen. And then, but more importantly, we have to learn what doesn't happen and why it doesn't happen, and then try to do something about it. So that's always a little puzzle. I'll get to the lack of protocol stuff later when I have an answer. So, but that's kind of what it is. And I think having the recordings will allow people to look back and hear it again and practice that, because in labs we do it. I do a demonstration of it. We have a video playing during the lab, and still people don't get handholds right, or they don't get pressure right, or it's amazing. Like, so we can, but it's a great way for them to go back and look at it. Yes.
Yeah. Well, Normally do a couple rapid fire questions to introduce people. I think we're probably going to know one of the answers of like your favorite body part to treat. It's probably going to be foot or ankle there. But what about subspecialty within that? Like, what is your favorite pathology within the foot or so? Like, what's your like, I just love working with plantar fasciopathy, or I just love working with metatarsalgia. Like, what's your favorite thing to treat?
I like almost the posterior tib or pronation, delayed pronation, prolonged pronation, things like
Yeah.
that. How can I get out of it? How can I
Okay.
get them to get out of it? And
Yeah.
there's definitely some tools and tricks that we've learned along the way in practice, and mainly creating exercises that force you to decelerate pronation,
Yeah.
and that's challenging. And people do it. You know, they see me do it. I've done it a few times, so it's pretty easy for me.
Yeah.
But then they look at it, it's like, wow, this is a lot harder than it looks. And
Oh yeah.
I can sit there and talk to your blue in the face about how to do it, but they've got to feel it. You know,
Yeah.
they've got to feel it. And then, yeah,
All right,
let's
now
go
you
with
got to tell us what the exercise is here. Hold on. What's this glorious exercise here? Because I love treating
that.
the same diagnosis is fun because I feel
Yeah,
like it is one that you can really affect change on very quickly.
yeah,
And there are a lot of tools in the toolbox, and it's a multimodal approach, and you can get results fast. And people feel like hopeless about it, so you become this big hero to them. So, what's
correct.
this magic exercise to
It's
decelerate pronation here?
it's a tough one, and sometimes they don't get to it the first couple of times. But
Right.
it's a single leg balance, right? So single leg
Yeah.
balance. The band or tubing, whatever is coming from the wall, so you're going to hold
Okay.
at your waist, and then like say I'm on my right foot, the
Yeah.
band coming from my left side. So I'm
Yeah.
standing on my right foot. I'm going to internally rotate my right leg or rotate out,
Yep.
and I can go a little bit or a lot. And as I come back to neutral, I'm only going to neutral. I don't. The band can't pull me into pronation.
Oh, nice.
So they
Yeah.
can do that. So ways to help or assist with that, they can raise their big toe up. I think that's
Okay.
one of the most overlooked things in the foot.
Yeah.
Raise the big toe up. That's going to plantarflex the first ray and create the arch. So that
Yep.
gives them a little break, gives them a little help to do that.
Oh,
And
use
then
that as like a regression almost for it.
yeah, yeah, yeah. And then once they can do it, then they increase the speed, they get more resistance, and it's going to work the hip and the foot. So
Okay.
people have complaints either foot or butt, they feel it. And
Yeah.
so that's my favorite one to go to at some point. Yeah. But a lot
Nice.
of times they can't do it day one, but they'll get there. They
Right.
can't raise their big toe.
At the appropriate stage, right? There's lots of clinical
Yes.
factors that
Yes.
go into that, but that's a critical aspect of it to teach that deceleration phase of it there.
Right. Right.
Nice. That's awesome. I love that. That's a good practical application there of it. So, we talked a little bit about when the foot hits the ground already, but could you sum it up in 2 to 3 sentences what somebody learns when the foot hits the ground? Course, like, could you like, what are the key takeaways of like somebody that takes it? What are they able to do after they take it?
I think they can evaluate the foot for one thing. They
Yeah,
can evaluate the rear foot, mid-tarsal joints, forefoot, and see what they're looking at. They can
yeah,
kind of get some ideas of what to expect, but it's going to fool you because the foot is very tricky at times. But trying to simplify it and don't let people be afraid of it.
yeah,
I think that's the biggest thing is people in PT schools around the country. Not a lot of emphasis is put on the foot,
yeah.
and there are some, but the majority of the time it's not.
Why do you
And
think that is? Why do you think that there's a de-emphasis on the foot?
I almost think it's too complicated for students. Would be my thing.
Yeah,
I spoke with one of our instructors here at the University of Puget Sound, and we're just doing a subtalar joint neutral lab. So looking
yeah,
at how can we bisect the calcaneus and draw a line on it. And he wants to take it out because he doesn't think that the students can draw the line right, or they have problems finding what the middle of the calcaneus is and to bisect it. And then once they get it, they can't find what neutral is. They can feel the talus and they can take the forefoot, move it, but they can't feel what neutral is.
yeah,
And so that he said his neutral was, let's just have someone stand on a wall and look at them from behind. If they do a heel rise, does the foot stay neutral, go into inversion or whatever? And I'm like, how is that? They
yeah,
can't do that. So I think they shy away from it, to be honest, because it can
yeah,
be a little tricky.
yeah, yeah. It's complicated structure, right?
Yeah, but I
It,
think going back to your original question was if someone can know what the rear foot does and the line
yeah,
on it, what the mid-tarsal joints do, forefoot does, they can identify the foot type. And then between those foot types, this is pretty common what's going to happen when they walk or stand or play, run, jump, whatever. And that's, I think, to identify the foot type, and then of course what to do about it. There's several things what to do about it during class that they'll pick up on.
So let's go into that a little bit more. We had talked about some questions ahead of time, but I'm going to jump around here a little bit.
Sure.
Because, I've seen there's a decent amount of literature that static foot postures aren't always able to predict injuries. And it's not as always related to what's dynamically happening during something like gait or movement or jumping or things like that. So, is there new literature to the contrary of that, or what should we be looking for at the foot that is impactful for something like walking gait, or how do we use foot structure and function in a way that can inform decision making that's approachable for the typical clinician type thing?
Yeah, I think, go back to the main one out there, the static foot posture index. That's it's being used more often lately, because doing the research last year or so, it's been coming out with running. They look at it, they could static foot posture index, they do a 5K run, retest it to see how much it drops, to see what the numbers change with it. I personally don't use it in class, in mine. I think it's a great thing. Here's what I tell people in class. They're aware of it, to make them aware of it, how to judge it, how to score it. We don't practice it because I said it's out there online. There's great YouTube versions of it. And but at the end, it does not equate to static to any movement.
Right.
So I say it's a great thing at the end of a run. If you're working races, how do you get people to come talk to you? So,
right.
Hey, what's your static posture index? What's your score? That kind of thing. Get people to come talk to you. And then you do the score, they give it to them. They don't know what it is, but the bottom line, they came and talked to you. That's it's great for that.
See what your score is. It doesn't matter what the score is, but come see what your score is here.
But I think I've not seen anything out there that's that great that you don't have to put your hand on the foot to test it. And I think if you're looking at the foot, if you know the rear foot doesn't move very well, doesn't go into eversion 10 degrees or so, that person's going to be on the outside of their foot. But when I'm watching someone walk away from me and their rear foot doesn't come to neutral, right?
Yeah.
Is it a rear foot problem? Is it a forefoot problem? Is it a rear foot that doesn't move? Or is it a plantar flex first ray that's rigid?
Yeah.
Basically, the foot did its job. It got the big toe to the ground. So the rear foot doesn't have to pronate anymore. So, but where's it coming from? You have to dive in a little deeper.
Right. What's the compensation like? How are they compensating in the absence of one thing, and how could that be related to what they're there to see you for?
Right. Yep. And then if someone is on the outside of the foot, you're going to expect the lateral structures, the tendinopathies to come into play. Some forefoot stuff. Typically have a high arch foot, tight calf, all that stuff. Those things start to pattern. You start to see over time, and just go from there.
Yeah. So with that being said, like if you could just assess one thing on somebody's foot and you had to do the same foot assessment for somebody every time, what would be your go-to, or what would always be the first thing that you would assess or look at?
I'm going to assess it all in about 20 seconds, but the mid-tarsal joint stability is what I want to know. If I pronate the rear foot, does the mid-tarsal joints unlock? If I supinate the rear foot, do they lock up? Or do they become a lot stiffer? They don't have to.
Yeah. And how do you test that? How do you look at that specifically?
So they're in long sitting. I'm going to take the rear foot and pronate it, or evert the rear foot. And I got the oblique axis and the longitudinal axis. So I'm going to take the foot and go on oblique axis, test it, and invert and evert and test it, because those two joints work together. And then I'm going to supinate the rear foot. A lot of times people don't supinate the rear foot strong enough or hard enough. So they get more movement. So it's not an accurate test. So one of the things in class that we'll go through is how to actually kind of drive in a little bit and twist and supinate the rear foot, and then test the same motions we just tested. Are they now stiffer? Are they move less? And so that tells me, as they get off the rear foot during gaze, they transition midfoot to terminal stance. Do I have stability there to work with, or not? And then I'm going. That lets me. Do I go back to taping? Do I go back to orthotics? Do I have to? What do I want to do about it?
Okay. So you're more, let me see if I'm understanding, you're more worried about their ability to create stiffness in the foot than their ability to absorb forces. Like do you ever see the inverse where somebody is just like, they can't loosen up, or what do you see with that? Yeah.
But that's the ones we just talked about. If the rear foot's inversion, they're going to be on the outside of the other foot. But is it a rear foot problem, or is it a forefoot first ray stability problem? If they're lack of mobility in the first ray, does it actually plantar flex and allow the hallux to dorsiflex, which that type of foot it normally does.
Yeah.
But am I going to address rear foot? So how I would assess that is I have them stand and go neutral, put them in neutral standing and relax it. If they don't move much or they actually more in inversion, then I'll take the forefoot off the front of the box and take it out of the equation, and then see if the rear foot can go into eversion, takes in the forefoot out of it. And that way assess, because then you got to know what to treat. And the other part, the harder part with the ones that are inverted is you can't force motion that's not there. So it seems simple, just put a big lateral wedge on the outside of their heel and force them into eversion. But if they don't have the mobility, they're going to hate you, because you're going to end range tissue tolerance every time, and they're going to wake up with a sore ankle. And they just can't do it. So that goes back to joint mobilizations. And then with joint mobilizations, we do static, we do mobilizations, active, and then we'll tape them in a fibular or posterior fibular relocation taping. And that's going to allow them to evert more every time they walk. So every step they take, and they're continuing their mobilizations.
Yeah. So is that the simple taping where you just do a push? It's like, and it kind of wraps around the backside of the tibia, or are you doing it like?
Yes. But when you put the tape on, you've got to pronate the foot to unlock it, and then drive the force down, drive the fibula down, and pull the tape down hard, and then come up and around the backside.
Very good.
Even training rooms I see don't do a lot of that. So the training rooms I've been, we actually, it's fun to teach athletic trainers something new. They do a lot of taping, and I appreciate what they do.
So what kind of populations do you see have the most issue with that? Is it like a running is there within the running population you see something? Does that correspond with other mechanics that you typically see? Or is it like a geriatric population? Are they going to become stiff? Are they going to become weak? Or what kind of patterns do you notice around this?
Yeah, usually you'll see it in the late 30s, 40s group, and then that's when it really starts to stand out. But if someone has tibial varum or genu varum, that's when you'll start to see that as well. But what it does, if it's not treated, you'll start to see the metatarsal heads drop down, the claw toeing, all that with the tight rear foot. And with treatment wise, I still like to try to give them something. And even when it's an orthotic that helps them force over, a short lateral flange on the orthotic device to help them go. But I always start with taping, shoe wear, and that. But the population, what it leads to is chronic ankle instability.
Yeah. And
that's what I'm trying to, if I can prevent that or try to slow it down for years early, I want to address it that way. I don't want to wait till they're 60. I mean, I can just look at people, because I definitely geek out and people watch all the time. And so if I see someone standing and they're on the outside of their foot, just standing there, I mean, that's never a good sign. That's going to lead to chronic ankle instability. And as much as we travel, right, airports, and it's great people watching airports, and you feel like just pull them aside and say, hey, can I tape this, or can I try this, something real quick? And obviously can't do that, but I think this trying to catch it early. I'm friends with one of the pitchers on the San Francisco Giants, and so his mom was telling me that he's got some claw toeing going on at 28 or whatever he is. And so we addressed that. I was there at the game with them at Boston, and so we addressed it, and he's got orthotics on the way. And not that he's going to pitch with them, but that he can wear every day. That's going to help put a little bit of pressure behind the metatarsal heads, straighten his toes out. But lack of ankle dorsiflexion is the number one reason for that. And so he has, normally you want about weight-bearing dorsiflexion about 53 degrees, and he had 38 on both sides.
Okay.
And so he said the trainers,
like the tibial inclinometer, or are you measuring that
on my phone? Just on my phone. The measurement section of the phone.
Measurement. They're just in like the lunge position, and they lunge forward. Yep.
It's the little.
Oh yeah, that's an underutilized update. When that came out with the iPhone, I was like, oh, thank goodness! Like all the digital inclinometer people went out of business, unfortunately. But everyone else is really happy. Yeah,
price is a lot cheaper for this one, and it's So and he's in his case, they said, we're trying to stretch my calves out all the time, and you can, but is it a joint mobilization problem? Because he doesn't really feel much of a calf stretch. It's a joint mobilization problem. So if we can get something to move correctly and basically just prolonging it at this point, it's not a whole lot of ankle dorsiflexion. So it's an issue. But I would Yeah, I can talk about that forever. But
Yes. All right. Well, now, okay, next stage of this, and we're doing a little deeper dive. We talked about more segment, but I like this deep dive we're going into. All right. So mobility is not ability, right?
correct.
So you are saying like we're checking out what the forefoot does as we kind of control and manipulate the rear foot, and we're looking for locking, unlocking. We're seeing how that responds. If we find something that isn't doing what we want, we might be mobilizing it to get some extra motion on there. How do you transfer it into gait? How do you, because, just we know that mobility is not ability. So you give somebody extra dorsiflexion, you give somebody extra first ray mobility, you help them get to the ground. It doesn't change it. So what do you do to get them to utilize it while they're functioning?
Taping. Simple answer. It's taping.
Taping.
So we'll either do a navicular sling taping,
Yeah.
which gives them stability through the mid-tarsal joints or through the arch, allows the first ray to plantar flex. And also, if it's a rear foot, we'll do the posterior fibular relocation to help them evert the rear foot every step. As far as gait, I try, again, we get 45 minutes to an hour with them.
Yeah.
I don't want them to have to think about every step. I've got to raise my toe, or I've got to do this, I've got to do that. If it's taping, let the tape work. In the mornings, it's something simple as plantar fasciitis, whatever. In the morning, they step out of bed. One of my cues is raise your big toe. If it hurts to get out of bed, do some ankle circles first, and then you walk into the bathroom, raise your big toe up.
Yeah.
If you raise your big toe up, you're going to plantar flex the first ray and maintain the arch height. You can't stretch the plantar fascia. And so and they don't have to do it forever, but with that 5, 6, 10 steps, whatever, to the bathroom. And then once they're in there brushing their teeth or whatever, then they can do some ankle dorsiflexion stretching from there with the big toe up. That's the emphasis. I emphasize that. And they should be okay.
Extending. They're doing active hallux extension. Yeah.
Yes.
Kind of like a toe yoga type exercise.
Yeah. With they can raise it. It's gonna plantar flex and keep the arch height up, and you can't stretch your plantar fascia. When those mechanisms there, they're not stretching it. So that's
kind of my there. Yeah.
Yeah. But so as far as telling someone narrow your stance, widen your stance, push off more, land more on your heel. If it's something that obvious, I'll mention it. But I think that where we get in trouble is if you see someone walking away and they've got all 5 toes pointing out the side instead of just 2 lateral toes. Can you say turn your foot straight ahead, or can you turn your foot in some? You got to go back up the hip mobility and make sure they have enough internal rotation to do it, or you're going to trash the hip joint. So you can't. Going back to your question, one thing I would look at? You have to assess it all, but once you do it, it doesn't take long. In my class, in our class, I'll show it as an example. I'll go through it, show as an example, and then I'll take someone through it. But my example in our picture up there, it's 34 seconds, and I assess the whole rear foot, forefoot, midfoot, everything. It's 34 seconds. So it doesn't take people long. You just got to get used to it. You got to do it more than once.
To look at. You got to prioritize and look at it there. And 100% agree, right? Like that's why, we do a lot with gait, and we have the gait categories. We talk about all those things, and gait retraining is a big part of what we teach in the certified running gait analyst courses. But at the same point, if you don't understand the mobility of what the rest of the body is doing, to your point, you see too many toe sign, and you're not understanding like, well, this person lacks internal hip rotation, and so you're going to them to internally rotate and put them at an end range and try to run at that, and they're going to hate you. So you have to consider the whole person and the whole structure and how it's going to impact other structures as you look at those things.
Right. And the same thing, they may typically they're going to turn their foot out because they don't have enough ankle dorsiflexion. That's the biggest reason, one of the compensations. So one of the compensations, turn your foot out. But what that does is takes the oblique axis of the foot, and now it has the same structures, the same movements as the talocrural joint. Now by turning your foot out, the oblique axis is straight forward. Now it's essentially a second ankle joint. And so if you take that away from someone by blocking it with an orthotic, they're going to hate you for that too. It's an orthotic failure. And so it's just knowing all those bits and pieces. And class is great. We dive into that a lot and mention it several times, and hopefully we drive it home. But if someone does the online course, there's no reason they can't go back and listen to it. And I can tell my kids, there's no reason to be dumb anymore.
You can go back and recheck and get all the information. It's access is there. The guidance on how to use it is the key now.
Yes, absolutely. But it took again, I listened to that course 40 times with all the other instructors, and I picked up bits and pieces of all the time,
every single time. Yeah.
So that's why I'm excited about this online. Gives people a chance they don't have to travel up and down the West Coast like I did.
Yeah. Yeah. Save some frequent flyer miles there.
Yeah,
exactly. And still get the information. But it is important. And it's important that you can apply it to your own situation. You can have it with your own patients and review it and access that. So, all right. Next question I was going to ask you too about that was a fun deep dive into that here. But what's the biggest thing that you've either started doing or stopped doing in the past few years because of some type of advancement in the research or some type of new understanding of foot biomechanics?
I think the thing we've stopped, and it's not just the last couple of years, but for a while, has been modalities. I just don't do a lot of modalities. And I always tell our students and patients and PTs, whatever, is everything you do in treatment should have a reason. Mm-hmm. Don't just give them an exercise. It should be for a reason that you're thinking about. And so I always make fun of ultrasound. I say, well, if you're doing ultrasound because you want 7 minutes to think about what the hell you should really be doing, you're doing it for a reason. So know that you're not going to get the benefits. But
there's no, we're not getting the thermal benefit that we're projecting there. But
modality is the big thing. Yeah, we don't do really anything. Now neuromuscular electrostimulation stuff come into play, or blood flow restriction. I mean, if we're going to call those modalities, yes, we definitely will do that. I think blood flow is one of the bigger things that's come in over the last couple of years. We've had Owen's device for years, but we use it probably
phenomenal
more
for the foot, right? Because it's how do you load up some of those structures and put them under the tensile loads that they need to develop true strength? Well, it's actually really great application of it for foot exercises, utilizing that in conjunction with what you're doing.
I mean, the Achilles is amazing how strong it is and what it can withstand and how do you load that? So it's interesting to play with that. But I think, we've still been pretty consistent. I think orthotics we've gotten away from, not totally away from by any means, but when I first took the class, it was cool because you could cast, you were the cool guy to make orthotics, and something that no one else was doing. And now, over the years, I bet I do 1 to 2 pair a month. Whereas I used to do 8 to 10 pair a month. And because I think treatment's involved with the research out there and trial and error, to be honest, a lot of that. And what works and what doesn't. That's where we've kind of gotten away from the orthotics. But I certainly still use them for that certain foot types.
Yeah, there can be a time for some of that and a duration. I think that's an important thing too, is there's rarely a fixed deformity that needs a orthotic for life type thing. We should be looking to shift loads for a certain amount of time and corresponding that with certain exercises and making sure that that person has a expiration date for the orthotics there. I think that's where we were for a long time, where it's you're going to wear these orthotics and every 2 years you're going to come in and get a new pair type thing. And it's we can't be moving that way.
I will look at if someone's an older person, let's say, that has a flat foot or just, there's nothing there. There's not much to work with. And they come in and they want them. That's what they want. Or they want a new pair. They want something else. I don't mind jumping early to that because I know they're not going to do foot intrinsic exercises. They're not going to do exercises at all. They don't want that. They want to walk around the neighborhood. I don't mind jumping to a little bit there earlier. Or if someone has the mobility problem, can I help? I am a user of them because I've got a supinated foot with the tendon tear on the outside, and but I like my little heel lift. I like my short lateral flange and my rear foot eversion that forces me into eversion, and I feel so much better walking with them on. But I also have a plantar flex first ray, so I've got it cut out. So I have the perfect foot type for my device. And if I don't wear it for a while, I can tell. But my tendon, it's my ankle is a whole nother reason. As we get older, we hurt more, and we find we tend to treat ourselves a lot more often. And
it's so beneficial too. I learned things as I personally tore my patellar tendon last year, and it was a great professional experience for me. I was didn't want to do it, but it was really helpful.
Yeah, absolutely. I'm going to an orthopedic surgeon actually when we get done here to find out if he has anything new or what he can tell me how he's going to fix my longitudinal tendon tears on my peroneus brevis. I got to see what we can do. I've talked to. That's the good thing about surrounding yourself with good people. I can reach out all around the country, and I have, and no one's got a solution right now. And I'm actually speaking again at that OSET meeting in September. So there's a whole foot and ankle orthopedic group that comes in there. So I will be, if I don't do anything about it before that, I will be picking surgeons' brains there and say, use me as a case study. And I love it because it's a case study. Use me as a case study, and I'll have 8 surgeons up there. Tell me what you're going to do. And that's, but we get to do that with a lecture, with the knowing the right people, let's say.
Yeah. Those, you say the longitudinal tear and the peroneus longus.
No, brevis.
Yeah.
So it's just, and I had surgery with it back in January. And I knew I had a bone spur that developed over time, and I said, I don't have time to be in a boot and for months or whatever, and just take out the bone spur. So he agreed, he reluctantly, but he agreed. But I don't want to go through the whole calcaneal osteotomy. I don't want to do it.
No.
So I'm searching for answers, but
yeah, that's a tough one there. I've seen that before. It's a brutal pathology there that can be really tough with it. Now, do you, kind of going back to the technology aspect of it there, I'm obviously biased. I have used a lot of technology in my clinic here and really find value in it there. What do you utilize technology in either your assessment of foot or gait or anything there?
Yeah, I think with gait-wise itself, I mean, I wish I could afford the WalkerView, the Woodway WalkerView treadmill, because that can tell me everything I need to know in a short amount of time, but it's expensive and I don't have the space for it. Your technology is, I just don't have the space, the time, but I think it's great. I've seen it. I've seen it at the conference. We played with it. But as far as foot stuff, we used to have a force platform that really hits home to people. And if someone with Achilles, can you just shift weight to your forefoot? I am. No, you're not. Look at the TV right in front of you. You're not shifting weight. So I think it's I love visual feedback stuff, whether it's on the treadmill, we basically videotape them, and then we'll go right through an iPad in slow motion and say this. My population, you obviously see a lot more advanced runners than I do. For the most part, mine's to say, fix me. I used to love it. I used to love going, oh, look at this angle and this is it, and to explain the whole thing to them on Dartfish and the whole thing. And then they look at you like, just fix me. Just tell me what I need to do. But I like the videos. That's why I say the numbers, all the assessment number stuff. I don't do as much of it. And we can, but very few of my people are that geeked about the numbers. You're a completely different group. I get it.
It's they want actionable numbers, right? And they want to know, they don't need to know 60, like our computer system, we built an algorithm, it interprets over 60 data points, and then it says you're an overstride or knee drive. And they say, okay, great. I need to drive my knee. Okay, fine. They're like, that's what they want to know. And they might go back and look at some of the numbers like, oh, that number went from 32 to 29. Is that significant? They're like, yes, that is significant. And like, I do believe we have to really show the value sometimes because I think what can be hard, especially for very experienced clinicians, is that we had done things so many times and know the value of it that sometimes you forget to explain to them like the significance of what just happened. Like you mobilize somebody's foot and now it's like goes from locking to unlocking and you're like, oh, great, phenomenal. Like that's just a Tuesday for you, right? But for them, like that's a big thing. And so I think one of my soapboxes in the physical therapy profession is that we don't show our work enough. And we don't really show people the value of what we do. And that's why they don't always value it as much as we'd like them to.
Yeah. And the test-retest, I mean, that's obviously, I know you're big on that. And so am I. And I tell my patients, and I don't discredit chiropractic treatment, but I tell them, I've been going for 10 years to chiropractor. Is it working? What are you doing? Do you still have pain or why? And I ask them, I said, what motion can't you do before you get on the table? And sometimes they have an answer, sometimes they don't. And then I say, well, then when you and he or she does their thing, and when you stand up again and do that motion, is it better? And nobody does it. Nobody tests that.
No.
Why?
PTs are the same.
To be tested.
Yeah, PTs are the same. They're not testing it, right? Like they're not looking at it. And, I think total knee replacements is probably the most common, that at least they're measuring knee flexion before and after, but it's not even a functional type thing. But,
Right.
we need to be looking at that. Like, how can I move better? Because
Yeah.
if you're not doing that as a clinician, you're not learning each time either.
Yeah. I mean, I'm a big Gary Gray guy.
Yeah.
I started with him. And so that's why a lot of my functional reach tests, a lot of my single leg balance exercise stuff, a lot of it came from him
Yeah.
years ago. But we still do it. It still puts a number on it. And people
Yeah.
always want to know, just whatever, single leg anterior reach test. And they'll say, what I get last time or
Yeah.
whatever. And so for the most part, I definitely have a competitive group, but not to the point where they want to say is 5 degrees to 7 degrees. They don't care. They do it. But I like when I do the video gate. If we do a video gate and we show them, first of all, no one's ever seen themselves walk or run, and you watch them walk, and the first question, first big comments, of course, either clothes or my butt. That's obviously the two that you get.
That's why
People talk about.
we took the 2D out of our 3D motion analysis because it distracted people from like the actual stuff that mattered, because they're like, is that what my butt looks like?
Yeah, exactly.
Let's show you what matters.
But I think if we could show the hip drops, we could show the obvious things to them, and without putting a number on it, and say your right side's dropping more here, and freeze frame it in certain motions and say it's dropping here. And then when we go to do a single leg hip abduction exercise, whatever, this is why we're doing it, because remember when you hip drop, and this is what in function standing, this is what we're looking at. And so we kind of definitely relate it back to what we saw, and this is why we're doing it. Again, going back to every exercise should have a reason. So yeah, we get good results, good success with that. But I think that as far as technology, the Force platform is a big thing. And honestly, Doug, my group, they're not geeked out like we are.
Yeah.
They're great what they do. They come there, patients come back, they love them, they do that. But as far as getting them to hang around afterwards like we used to and hang out and talk for an hour or talk like this, they don't do it. They're gone. They're going to work out. They're going to do their own thing. Now, I'm going to look back and say, who's the dummy? I don't know.
Yeah.
I don't know. Yeah. Maybe they're smart for leaving that and go and do stuff. I don't know.
Better work-life balance than us, maybe. But I would say I have great work-life balance here, because my work is my life. I love what I do. There's no difference of like, oh, I'm not doing what I want to do right now. So,
and that's what the retirement part. People keep saying that. People keep asking me how many years you have left. I mean, when do you want to retire? I'm like, I still love what I do. That's the hard part. I mean, it's frustrating because people don't geek like we do, but I still like the patient interactions. I like getting people better. I like the showing a positive influence on someone and making fun of people and having fun with people. We have great patients, and I'm going to miss that. I'll miss the day they talk. And I got a few years, definitely got a few years left in me. But
my definition of retirement is, because I don't think I'll ever not work just because of who I am. My definition, I will only do what I want to do when I'm retired. It'll be that kind of like, I'm not going to do that. Like, nope, I don't. That's not my problem. I'm just going to do what I want to do. That's my definition.
And when I want to do it. Yeah.
And when I want to do it. It'll be on my own time. And it'll be, I won't deal with anything that's not absolutely necessary for me there. So
I know we get to travel, we get to teach and have fun with it, but it's still work. I mean, bottom line, it's not like it's still work, and you're under the gun. And I want to put on every day. I want to put on best performance, whether it's in the clinic or in front of the room. And that's you have that in you. Anyway, that's fun stuff.
I feel like we could keep talking and nerding out about lots of foot stuff and structure and function, but maybe talking about retirement is a great segue into the transition here. But so how do people find out about you? Where can they find information about the course for you, the clinic? Like, how can people get a hold of you?
Yeah, mine's just paul@3dimensionalpt.com is my email at work. And then the class-wise is whenthefeethittheground.com.
Perfect.
So whenthefeethittheground.com has our website on there, has our locations where we're teaching coming up, how to sign up. The online will be on there again very soon. Keep checking for that. And hopefully we get more questions from the online, because I don't want to stop the interaction. I love the questions, and I know dumb questions. Just ask, and I play dumb very well. I'm okay with that. That's how you learn, though.
Yeah. Yeah. You can't be afraid to not know the answer to something, right? Because then you'll never know. And that's the real crime of it. So awesome. Well, Paul, great having you on. Thank you. Really love deep diving into some foot stuff here. And we'll have to, at the next conference, we'll go into another deep dive on something fun there. So
you can be at the sports conference in June?
Unfortunately, Vegas? I will not. That is, my wife is taking me on a surprise trip for my 40th birthday, right then around that time. But we'll have Scott Greenberg there. Yeah, baby.
Yeah. I'll talk to Scott. Oh, so I'm actually doing the panel with Scott at OSET. So yeah.
Oh, perfect.
Good guy. Good guy too. Yeah.
Yeah. So I'm at ACSM next. I think I'm in ACSM in a week or so. Week and a half or so. But we'll have to catch up. But
thanks for doing my first podcast. My very first podcast. I appreciate it.
Yeah, so, great job.
Hopefully many more.
Yeah, many more. So, all right. Well, thanks everybody for listening here. And make sure if you have, keep up with the conversation, head over to rundna.com. Make sure you're on our newsletter where you can hear about these podcasts and you can hear about other information and webinars that we do. And thanks for joining us here. If you want to see any of this stuff, some of the motions we were going through or talking about for some of the exercises, check out the YouTube channel as well. Thanks for listening.
Like what you hear? Leave a review of the show wherever you listen, and don't forget to subscribe so you never miss an episode. RunDNA helps runners and running specialists through education and technology to identify each runner's unique injury profile to avoid setbacks and maximize results. The RunDNA podcast is produced by Ace Running LLC. The RunDNA podcast is intended for educational purposes only. No clinical decision-making should be based solely on one source. While care is taken to ensure accuracy, factual errors can occur. Always seek the guidance of qualified medical professionals before making healthcare decisions. Find us online at rundna.com.